look at a proton dose distribution, look at the red line here. This is the 45 gray line, I believe. And look at this one. You can see the beams are penetrating much further in. And you can look at the blue line, which is a lower dose here, 10 gray, but it is penetrating far into the opposite lung. So these are the reasons that, this is just to illustrate that protons are affected to a greater degree by anatomic changes and motion, etc. And the solution obviously is periodic re-imaging and replanning. And we did a randomized trial, and what we finished doing a randomized trial, and the first 93 patients, 53 were randomized to IMRT and 40 to proton therapy, and only 20% of IMRT patients required replanning because the changes were enough. But 53% of the patients required replanning for protons. So robustness, I mentioned to you, robustness is important, and so is robust optimization. It is necessary for quantifying and minimizing sensitivity to uncertainties. And robustness can be improved through reduction of uncertainty. We can simply do imaging, be very careful about setting up the patient. We can do adaptation. But as I mentioned to you, you cannot eliminate all the uncertainties. So that's when you need to quantify, determine what is the robustness of the plan. And also, if it is not robust enough, you need to then use robust optimization. Robust optimization, by the way, cannot be used for passive scattering. Can be used only for scanning beam and IMPT. Just want to mention that. Traditionally, for photons, we have made plans more robust by simply assigning a PTV margin. As you may know, I think that's what the PTV margin does. What is it, after all? You assign a margin around the target volume so that the worst that can happen to the to the disease is that it may move around within so margin is sufficient to keep the tumor volume within that PTV so that it always gets the dose that the PTV gets, regardless of the motion, regardless of shifts its position, regardless of setup uncertainty. But that, as I mentioned to you, does not work necessarily for protons. Through robust optimization for intensity modular proton, we need to incorporate. So robust optimization is the equivalent or analog of assigning margins in the photon world. So this is an illustration of quantifying robustness. What you see is bands or DVHs. So so we create a plan, and then we shifted left, right, up and down, inferiorly, superiorly, the patient's anatomy. And then we also add range uncertainty. So there are 8 or 9 dose distributions. For each one, we draw different DVHs. So these are the DVHs. These are the bands of DVHs. This is for the clinical target volume, and this is for the lung. So these bands tell you the variation in dose distribution that can take place. The width of this band, for example, at 95%, gives you the quantitative measure of robustness. So but if the plan was robust through robust optimization, then you can see that the band is much narrower. And that tells you that this is more robust. Only recently, treatment planning vendors are beginning to realize the importance of that, and they're building these kinds of functions into their planning system. So robust optimization is critical for protons, and especially for IMPT. And you can see that they're more, lung dose distribution is more robust, and so is the clinical target volume dose distribution. Now for IMPT, I mentioned that the uncertainties are more of an issue for IMPT than for passive scattering. And this is the reason. So this is an example from Paul Scherrer Institute. What you see is a beautiful dose distribution, but it is composed of 4 very non-uniform dose distributions. The individual dose distribution of 4 fields are very non-uniform. But when they come together, they make this beautiful dose distribution. So they fit like a jigsaw puzzle to make this dose distribution. However, if there is uncertainty, then they will not fit. There will be hot spots and cold spots within the tumor volume if that happens. And that is why IMPT is more sensitive to uncertainties than, say, passive scattering or IMRT. So I gave you this example, partly this example. This is what happens. So this is a conventional way of doing optimization. This is robust optimization. You can see the bands narrowing, and this is the same thing as I mentioned to you. So this is the same example. There's nothing here to add. But so the point is that robustly optimized plan is more resilient to uncertainties if the uncertainties are considered in the optimization process. But there is another aspect to it. What robust optimization does essentially internally is it is creating gradients so that when things shift around, the dose distribution becomes less sensitive to motion or changes. So even if, when that happens, even if things that are not considered during optimization, they become also less sensitive to changes. For example, if I created a robustly optimized plan in which I had considered tumor motion, but I did not consider changes from, say, week to week. But what happens, because the gradients are made shallower in individual beams, the dose distributions become less sensitive to changes from week to week. This is what we have found, which is very fortunate because it is very difficult to consider in robust optimization the weekly changes because we don't know what those weekly changes are going to be. We know motion, we know setup uncertainty, but very hard to predict how much tumor is going to shrink by next week. So this is a very interesting result that we found, that even though we did not consider changes from week to week, the dose distribution became less sensitive to such changes. So as I mentioned, we assumed 1.1, but there is plenty of evidence that that is an approximation and which may not be good for the patients. So question that by the way, I gave some of the slides I showed in a talk in Geneva that I gave last week, and so I posed questions. Is it appropriate to continue using our relative biological effectiveness of 1.1 in clinical practice? Would the use of variable RBE, in other words, if we could make use the RBE that is more like what we see in laboratory, would that help us better understand clinical outcomes? Would it make IMPT more effective and safer? And then what do we need to do to actually make that happen? How do we actually incorporate variable RBE into treatment planning of protons? Currently, all what we do is we do a treatment plan, we multiply dose everywhere by 10%, and we think that is a proton dose distribution. So this is from a paper by Dr. Paganetti, and he assembled data from literature, and what you see is there are large error bars. There are many, many experiments done over the decades to determine relative biological effectiveness of proton therapy, and then he put it in some kind of a blender, and the average value came out, which was 1.1, and for the last many decades, everybody has been using 10%, and when somebody questions it, they claim that it doesn't make any difference. Maybe it does, maybe it doesn't, we don't know. But it is based on limited, large number of experiments, but done in a limited way. They were all done at high doses per fraction, and they were done in the middle of the spread out Bragg peak. And that does not show the potential problems that can cause. And the justification is that it affects only a very small region at the tail end of the proton beam. So if this is the spread out Bragg peak of proton, they feel that it happens only in this region, and all you need to do is to extend the proton range by a couple of millimeters, and then if you multiply this by 10%, maybe a tiny little region here may be affected, but that's not important enough to worry about. They also said the clinical evidence to date has not shown that it does any harm to continue to use 1.1. Maybe we haven't looked hard enough. But I don't know who said that, but absence of evidence is not evidence of absence. It may be there, it just hasn't shown up yet. But to say just in case it is not 1.1, it rises to more than 1. So just to avoid any problems, let's not aim beam toward rectum or spinal cord or any other critical organ so that the distal edge of the beam where the RBE is high does not end up in some critical normal tissue. The reality is that RBE is a very complex function. It's a variable function of proton energy, in other words, linear energy transfer. And LET rises rapidly, but RBE rises even more rapidly than LET does. It is a function of dose per fraction. It is a function of cell type, alpha-beta ratio, or tissue type. And it is a function of endpoint, whether it's cell death or cell mutation or any kind of damage. Depends on what you're looking for. It could be changes on images. So everything, the endpoint determines the RBE. So there are many factors and perhaps more, for example, oxygenation level. The other point that I want to make is it's not just a linear function, it's a complex nonlinear function of all these factors. So here's an example where you see that this was measurements done by Wooters in 1996, and here's a proton dose, and you can see the RBE varies anywhere from about 1.2 to all the way up to 1.8, depending on dose per fraction. This is for V79 cells. And also depending upon whether the cells are placed here or here or here, this is for cells placed here, it is this curve. For cells placed here, it is this bottommost. So it's a function of where the cells are placed, and this is where the LET is different. LET is higher here and lower here, higher here and lower here. This is the work we did about a couple of years ago, and what you see is that the RBE is not a constant function, but it changes very, very much. This is where the Bragg peak, let me go back if I may. Oops. So this is where the Bragg peak is, and so what you see here is that at the Bragg peak, LET from entrance to the Bragg peak, LET is rising gently, linearly. But beyond the Bragg peak, it takes off, and all the way up to factor of 3.5. Although it is in a narrow region, but it is rising quite rapidly beyond the Bragg peak. So if the Bragg peak happens to be in some critical tissue, the biological effect will be much greater than simply 1.1. So this is what we found. And this was, for the first time, we showed that it is maybe doing harm to normal tissues if we continue to use RBE 1.1. By the way, these data show the complexity. The part of the reason maybe the complexity of double-strand breaks is higher when the LET increases. Another argument is made, as I mentioned to you, is that because the distal edge is so narrow, it's dropping very sharply, so that the effect of changing RBE is in a very small region. Well, but distal edge is not necessarily very sharp. When the beam passes through tissues, it degrades. Especially when it's passing through very complex heterogeneities, it degrades quite a lot. And this was an experiment done more than 30 years ago at MGH. And what they found was that if this was the distal edge in water, then after passing through complex head and neck heterogeneity, it had degraded to a point where the distance from here to here is almost 3 centimeters. So the changes in RBE are not confined to a very narrow region. They can be spread over a large region. So you cannot ignore the fact that it's only, you cannot assume that it's only over a small space. And again, the fact that assumption or the thought is the clinical data do not suggest that we need to make a change in our current practice. By the way, essentially, as far as I know, 100% of proton centers throughout the world use RBE of 1.1. I think people in Europe are now beginning to accept the idea that perhaps we should change that practice. In America, we are still kind of stuck, but I think my hope is that we'll be able to persuade everyone to start using variable RBE. One of the problems is that the tools, treatment planning tools, are not available for doing that. But there are, now we are seeing some toxicities that we never thought will occur. Especially looking at brain necrosis and spinal problems, some other issues. And so now people are beginning to acknowledge. The other issue often is that when there is a toxicities, there is a reluctance to admit that there are toxicities. You know, sort of shove it under the rug sometimes. And but now I think people are beginning to acknowledge that there are some issues that we need to do something about. But the other thing is, when there is a problem, there is not any one reason. There could be so many different factors why a toxicity occurred or why the recurrence occurred. So it may be very hard to isolate the fact that it may be RB. It could be the fact that maybe our dose calculations were not correct, or it may be that there was too much motion, or that patient had too much chemotherapy, or that some other genetically patients were most sensitive to radiation. So there could be many factors. So it may be hard to take only one or two cases. Unless we can accumulate a lot of data, analyze it very thoroughly, we may not be able to say, well, it is definitely the biological effectiveness. But on the other hand, there is probably no harm in using variable RBE. You know, the fact is that we know that it is changing, so let's go ahead and start using variable RBE. So here is one example that was presented by one of our residents, Jillian Gunther, at the ASTRO meeting in 2014, and since that isn't published. What you see is the changes in images, magnetic resonance images, and these are 36 proton patients and 36 photon patients. They're matched pairs. And what she found, this is a retrospective analysis of patients, that the changes in images, the intensity changed as a result of irradiation, and their changes were greater. More intensity changes occurred for protons than for photons, and the grade of changes, as you can see, grade 3 and 4 changes were the larger number of patients had grade 3 and 4 changes for proton than for MRT, and the grade 3 and 4 correspond to hemorrhage or focal necrosis. So higher percentage, and not only that, the changes in protons occurred earlier. So there is evidence now. This is a small number. You cannot simply say, and we need to understand why that happened, and that's one of the research projects that we are doing at my place. Try to understand, could RB have played a role in these kinds of situations? By the way, until we admitted that there are issues, nobody else acknowledged. When we asked people, do you see any kind of a problem? They say, oh, no, we don't see any problem. Now I think more and more people are beginning to come forward and say, yes, indeed, there are issues. Here is one example. It's a brain necrosis in a CNS patient, 40-year male with craniopharyngioma. And you see there are 3 fields, 2 laterals and 1 vertex field. And what you will see is that the distal edge of this beam and distal edge of this beam over here will have the area where there could be some danger, because that's the distal edge of 2 beams. Similarly, this beam here. And what we did some Monte Carlo calculations, and we used a simple model called a linear scaling model to calculate biologically effective dose. We calculated variable RBE using a model that's available in the literature. And we found that even with that simple model, that the biologically effective dose was significantly higher than what the ECLIPSE treatment planning showed us at the corner or the distal edge. And if you look at what this is showing is that this is the brown, the orange outlines are where the necrosis is outlined by the physician. That is all confined within the high dose and high RBE volume. So this is an indicator that this could possibly be a reason. So higher RBE could be a factor in causing this necrosis. Again, as I mentioned, that we cannot be 100% sure that RBE is the only factor, but that is pointing in that direction. So this is sort of my assertion, this is my hypothesis, that even though our current knowledge of RBE is limited, we are building that knowledge, it's not perfect, even then it is preferable to use variable RBE than to continue to use constant RBE of 1.1. It'll help us better evaluate proton dose distribution and help us understand what has been going on. If there is a toxicity, it'll help us better understand that. Not only that, if we include variable RBE in optimization, it will improve the quality of treatment plans. It'll create dose distribution that are more effective for the target and reduce the dose outside the target. And if you think about that, why do we use protons? The reason we use protons is because there is lower dose at the entrance and high dose at this point. If green curve here is the physical dose distribution for a scanned monoenergetic proton beam. If I multiply this by 1.1, I get this red curve, okay? Just 10% higher everywhere. But if I use variable RBE weighted dose, then what you see is the orange curve here. It is another 30% higher. If we continue to use 1.1, we are discarding this additional advantage that protons have to offer. And then when the results are not better for the proton, we say, we don't know why not, but I think this could help make protons even better than they have been so far. But the tools are not yet available. We are doing research. We're trying to create systems. I think I wouldn't be surprised if within a year or two, commercial vendors have adopted this and they're able to create plans with this methodology. So this is sort of work in progress at our place. This is the research ongoing. So we use the defined criteria of optimization of IMPT in terms of RBE weighted dose. And again, I'm not going to go into details here. But the models we are using are rather simple so far. They kind of underestimate RBE. The future models will be more like what we see in measurements, and I think they'll show even a bigger advantage that we have seen so far. So this is the model we have used. As I mentioned, we use Wilkins linear scaling model. And what it does is, Wilkins linear scaling model is this green graph here. This is what we have used. So it says RBE is rising steadily but slowly as a function of LET. But this is the measured data that we have, as I mentioned to you. This is our measurements. So, but we have not created a model that fits this data. We have just used this one so far. And even with that, we see an advantage. And this is that example. An example is for a head and neck case. What you see is that there are CTV1, CTV2, and CTV3. This is CTV1, the highest dose volume. I think it's 70 some gray, and this is 60 gray volume, and then the yellow is the 57 or 54 gray volume. So 3 different levels of dose. And then there are normal structures outlined. And what we see here is that if I can optimize 2 different ways. I can optimize the conventional way, or I can optimize incorporating variable RBE. And what I see is that after I have done it, variable RBE versus fixed RBE optimization, but then I recalculate the final dose distribution so they're represented in the same space. And the same space is that variable RBE space. And again, you see that there is an advantage, that there is more dose to the tumor volume than the high dose volume than if I had used fixed RBE optimization. And the other point is that the LET, this is an LET volume histogram. LET is higher. So LET higher means the biologically effective dose is higher in the tumor than it is outside. Then if I had used fixed RB optimization. Another point is that if I created a shell around the target, I created a 1 centimeter shell around the target, what this is showing is outside the tumor, in the shell, the dose, biologically effective dose is lower